From the County and City of Philadelphia, the behavioral health system. We're particularly pleased, Estelle Richmond. We've read about you a great deal in other places. We're glad to have you here. And Mark Benchavingo.
Yes.
Thank you. Welcome.
Thank you. Good afternoon. First, I'd like to present a picture of two consumers who have come into contact with the Philadelphia behavioral health system. Although service plans are individualized based upon the consumer's needs, these two consumers are representative of individuals who have come into contact with the system. First, she is 25 years old and a crack smoker. She's been reluctant to enter substance abuse treatment because she has several small children and she's afraid of losing them. She's in an abusive relationship, and she often turns to prostitution in order to support her habit and her partner's habit. She has recently established a relationship with an outreach worker supported by the Philadelphia Drug and Alcohol Office within the Philadelphia Department of Public Health, and she's expressed some interest in coming into treatment. Second, he's 11 years old and he has had numerous psychiatric hospitalization. He has behavioral problems and he has a great deal of difficulty maintaining relationships. He lives with his siblings, his mother and his grandmother, both of whom are under a great deal of stress because of their inability to manage him effectively. They would like to have some help.
There is no group for which fragmented social programs and fragmented health services makes less sense than those suffering from mental illnesses and addictions. Often it is difficult enough assessing any service, never mind a patchwork of separate programs, each with its own rules, regulations, and requirements. Throw into this mix the world of managed care, and the picture only gets messier. The Philadelphia Department of Public Health created a behavioral health system to coordinate care for people with mental illnesses and/or addictions. Previously, individuals seeking treatment were often pushed from one service system to another, none of which provided comprehensive care. The diverse funding streams had different regulations and restrictions. And to further complicate this picture, private behavioral health care organizations controlled the Medicaid services and dollars. Recognizing the fragmentation of the system, the Health Department's Office of Mental Health and the Coordinating Office of Drug and Alcohol Abuse Programs came together to create a third entity, Community Behavioral Health, or CBH. CBH is a city-controlled, private nonprofit Medicaid managed care organization that is capitated and at full risk. These three entities, the Office of Mental Health, the Coordinating Office of Drug and Alcohol Programs, and CBH successfully bid on the state Medicaid contract to create the Philadelphia Behavioral Health System. The behavioral health system provides services to approximately 100,000 people annually. This is from a base of 1.5 million Philadelphians, of which 375,000 are Medicaid recipients. The behavioral health system also acts as a safety net for folks who are uninsured or underinsured. The coordination of funding streams has allowed the behavioral health system to use non-Medicaid dollars to meet the social necessity needs of clients, providing supported housing, preparing people for employment, while Medicaid and other public dollars meet the medical necessity needs, providing treatment options. Over the past 2 years, the behavioral health system has had a number of significant achievements, including better coordinated services across all jurisdictions and funding streams, increased involvement of consumers of service and their families in service planning, policy development, and program monitoring, a commitment to hire people transitioning from welfare to work. To date, 25% of the CBH staff of 260 workers have come from this population. Realization of $51 million in savings. $14 million met the state reserve requirement. $13 million is being held for risk and contingency. And $24 million is available for reinvestment in public sector social services. And finally, and most importantly, increase access to mental health and drug and alcohol services, moving from approximately 300 community providers against 150 in 1996. The $24 million targeted for reinvestment will be spent on the following services: rental subsidies to aid people in seeking housing, enhanced outreach, treatment, and support services to people who are homeless, mobile therapy services for elderly people who are isolated at home, and consultation and education specialists in our city schools.
I'd like to go back to how the system responded to the first individual that I addressed. She did express interest in enrolling in substance abuse treatment. She entered a residential program where women can live with their children. In that program, she received treatment, and her children also were assessed and provided with the opportunity for mental health or drug and alcohol services, depending upon what they needed. In this case, it was mental health. During the course of her stay in the residential treatment program, she indicated that she had some history of sexual abuse as a child, and she was provided with treatment for post-traumatic stress disorder and dissociative diseases, and it went on from there.
Thank you. Lee Shore.
Do you feel that there are fewer severely mentally ill people in Philadelphia who are not getting served, not on their medication, et cetera, as a result of the program?
Absolutely. We feel that the number of people who are not receiving services, we have a handle on. We even try to reach those people who aren't at the point yet of thinking they need services by doing continual outreach. Because of the savings we've had in the system, we've been able to expand it, make it more accessible, and just provide more access in general.
Are you
throughout
able
the
to
city.
track people who are discharged from the hospital and out in the community to make sure they're taking their medication? Can you do any of that through the system?
We've had a couple of opportunities to do that. One, when we closed the state hospital in the city, we've been able to track those people very individually to make sure they're receiving services. Part of this initiative involved creating a large, fairly massive management information system, so we know who people are, where we are, and can begin to track how they move between the systems, which was part of the information we knew we were missing. That if someone went and got drug and alcohol services, we didn't know when they showed up in the mental health system, we had no information that they needed both. We've now begun to create what we call co-occurring initiatives, so we can treat the whole person, just not one thing at a time.
You sort of started to address the question I have, and that is data to determine how effective you've been. And developing a system for the collection of data is wonderful. My question is, how are you getting the clinics, the personnel down at the level to provide the data that you need to really address the issue of whether you're making a difference?
For the majority of the programs that provide these services, we are practically their only funding source. So we provide probably 90 to 95% of the funding those agencies get. To get the money, they have to provide the data. We've attached them together. Now, we will help them if we think they need help. We will work with them. We'll provide them with a computer. We'll provide them with as much technical assistance that they can get. But they won't have a claim paid unless we get the data. So the ability to pull in that data we have attached to the funding, and it has worked very well.
When I was reviewing your application, a thought that occurred to me, and I'd be interested in your comments on this, that in a way what you've done is you've figured out how to do the cross-subsidization that used to take place before managed care. Is that in fact what we're looking at here?
Yes. Essentially what we've done is when managed care came into Philadelphia with the private nonprofit corporations, the dollars that were saved, and they were dollars saved, went back into doing things that didn't supplement the public service. What we were able to do to figure out there was no magic in this is to do the same thing, except all the dollars saved now come directly back into the public sector.
I read in, I can't really remember, is it evaluator's report or if it was your application that you needed a new management system, and I wondered if that was in place and if that is allowing you to address, enabling you to address your clients' needs more effectively.
We're looking at enlarging the scope of our managed care, of our MIS system. We have a basic one in place now that gives us the data we need, that collects the information. We're trying to just broaden it so we can collect broader information and bring all that information together in one point. The technical term is a depository, and to have a sort of a data bank so we can put all of the health department and other data in it, so we can also know not only if someone has a behavioral health need, but we can also begin to look at some of their other health care needs.
I think I heard you say that you are a city-controlled but private, not-for-profit organization.
Actually, both of us work for the city. I'm the city health commissioner. What we did is that the health department created a private nonprofit. So the board of that private nonprofit are all people who are city employees.
But so, the employees of the nonprofit are not city employees.
The employees in the nonprofit are not city employees.
And what is that, what advantage does that give you?
That's a politic question. Not having the employees of the private nonprofit be city employees gave us an ability to get outside of civil service and to be able to hire people and to be able to control the flow of people where we are a fully at-risk organization, to be able to make sure we had the necessary staff quickly, to be able to make sure we could meet the opportunities within our contract with the state to, for example, focus on hiring people making that transition from welfare to work, and to make sure that we could be accountable for all the things that we needed to make happen.
Along the same lines, does that also affect the budgeting and fiscal allocation decisions by having a not-for-profit instead of?
Since we totally control that private nonprofit, the place where City Council has gotten involved has more been the budget for the Department of Public Health as opposed to the Medicaid dollars. About 80% of our dollars come from either the state or federal government. Only about 10%, or probably a little less than that, come directly from the city budget. So this is really controlling the outside dollars that come into mental health and to drug and alcohol historically, plus the Medicaid managed care dollars. Everything goes through the city treasury. None of it goes into the private nonprofit. In fact, the only money the private nonprofit gets is enough money to pay the claims and to pay their staff. The rest of the money is in restricted accounts